Hi, everyone. Thank you. I'm very honored to be here. This is a topic I care very deeply about, social justice. In my lab, we study the effect of childhood stressors like chronic poverty, maltreatment, social deprivation in the form of orphanage rearing, and how these extreme social environments shape child mental health and increasingly physical health. So I will start by talking a little bit about the allostatic load model. Brian already did a great job presenting the model. I'll just add a few more ideas to that, and then I will talk about potential lifelong consequences of experiencing psychosocial adversity in childhood and some potential ideas for interventions. This is a lot better than having me describe the figures you would have seen. Would have had a particular challenge describing this one, but believe it or not, this is the most simple depiction of the allostatic load model that I could find. So what's being highlighted here is that the brain plays a central role in interpreting threats from the environment. This could range from environmental stressors, as Brian described, work, home, neighborhood stressors, to major life events like job loss or death in the family, to chronic stressors like trauma or abuse. And the brain interprets these experiences of threat, helplessness, or vigilance, and activates physiological stress responses like the HPA axis or the sympathetic nervous system you can see here. In the short term, these lead to adaptation, but as Brian described, if prolonged, these chronic activations of stress-mediating systems can lead to allostatic load or wear and tear on the body. The parts that complicate this model are the fact that there are pervasive individual differences in how you can see here that are based on genetics, developmental history, prior experience with stressors that shape how the brain interprets the stressors and also the physiological responses that are mounted. There are also a lot of behavioral alterations that happen when people are stressed. We all know how easy it is to resort to comfort food when you're stressed. So here, alterations in diet, smoking, alcohol use, a lower motivation to exercise can also shape our physiological state. The complicated part about the allostatic load model is that, as Brian described, there are multiple non-specific responses to physiological responses to stress that are implemented by multiple systems. So here you can see only a few of the potential mediators, including adrenal hormones like cortisol and DHEA. You have the sympathetic and parasympathetic nervous system. We have oxidative stress. We have inflammatory and anti-inflammatory cytokines. And all of these mediators have bidirectional interactions with each other. So when one of them becomes dysregulated because of the network they're in, others might become dysregulated over time as well. There are a lot of individual differences in terms of what type of disease people will develop when they are under chronic stress. Some may develop problems with metabolism like diabetes or obesity. Some might show immune enhancement or immune suppression. Others might show problems with cognition, depression, Alzheimer's, and others may show cardiovascular disease. This is because of these multiple interactions between these systems. So as you can imagine, this is very nonlinear. It's a very much dynamic system. So it's difficult to measure this in humans. So what people have tried to do to try to capture allostatic load in humans is to measure representative biomarkers across multiple systems. You can see here an example from a recent study where they assessed different indices of cardiovascular function, lipid metabolism. What you have listed there under cardiovascular is resting systolic blood pressure, resting diastolic blood pressure, resting heart rate. For lipids, you have body mass index, waist to hip ratio, triglycerides, good and bad cholesterol. You have then glucose metabolism, HbA1c, fasting glucose, insulin resistance. You have various measures of inflammation like C-reactive protein, interleukin-6, fibrinogen, E-selectin, ICAM-1. They had measures of sympathetic nervous system output, epinephrine, norepinephrine, and 12-hour urine samples, measures of HPA activity, cortisol, DHEA, and measures of the parasympathetic nervous system. So what they actually do is they assess all of these systems through different biomarkers and create a composite measure of allostatic load by adding a score of 1 for each of these biomarkers that is in a high risk range, which could mean being in the top 25% or in the bottom 25%, depending on the measure for these indices. When you use this approach and you create this composite measure of allostatic load, what you see is very pronounced gradients by socioeconomic status in terms of people's allostatic load. What you see here is in the darker bars, you have those with higher levels of socioeconomic disadvantage, and you see that they show the highest levels of allostatic load on that composite measure that I just showed you. And you see the same gradients whether you use a measure of childhood socioeconomic disadvantage, early middle age or late adulthood, late middle age, or a cumulative exposure to low socioeconomic status across the lifespan. So this is interesting and is raising a lot of questions about the pathways through which these gradients become instantiated. For me as a developmental psychologist, what's interesting is also what happens in early childhood and how we could measure allostatic load in children. This is very challenging because many of those biomarkers that I mentioned are not elevated until many decades later when people start showing early signs, for example, of cardiovascular disease. What we use to measure allostatic load in children, we often look at growth stunting, which is an index of chronic stress exposure. We look at the dysregulation of the HPA axis. Cortisol is a hormone that could be non-invasively measured in saliva samples and urine samples in children. In some studies with my colleagues, we have shown that, for instance, children who grow up in orphanages are adopted into the United States frequently show abnormal patterns of cortisol production throughout the day, a flattened diurnal rhythm as opposed to the more typical increase in the morning and decline across the day. Potentially suggest sometimes with high evening cortisol levels, suggesting potentially problems with negative feedback mechanisms, which are very important, as Brian described. We also look at behavior problems, so ADHD, aggression, and poor mental health outcomes, things like childhood depression. And increasingly, I've started looking at physical health outcomes. In children, obesity is an increasingly prevalent condition. We look at metabolic syndrome and asthma as well. So it's important to note that childhood adversity is not only correlated with concurrent alterations of physiology, but also there are increasing correlational studies in humans linking childhood adversity to long-term health outcomes. So I wanted to highlight this well-known study called the ACE study conducted by the Centers for Disease Control in collaboration with Kaiser Permanente in San Diego. This was an analysis of a very large sample of more than 17,000 adults who provided access to extensive data on their medical records and also their psychosocial histories. And also they completed this 10-question survey that's become known as the ACE survey that asks about their adverse childhood experiences, or ACEs. So here's what this ACE questionnaire has in it. It asks about experiences of emotional abuse, physical abuse, sexual abuse, witnessing domestic violence against one's mother, household substance abuse, so having a family member who's addicted to drugs or alcohol, having a family member who's diagnosed with mental illness or has committed suicide, parental separation or divorce, having a household member who's incarcerated, emotional neglect, and emotional abuse. And you can see the prevalence rates for each of these experiences as the participants endorse them. These are very high, higher than you would think. And also keep in mind that these are participants who can afford to buy private health insurance. So if we looked at the general population, these rates would be much, much higher. And in 2015, there was a national debate about that you may have heard about whether we should include this 10-question survey in routine medical visits. And some physicians are really reluctant and opposed to this idea. They don't want to bring up traumatic memories in a 15-minute office visit. And other physicians think that it would be really useful information to have because it might provide some information about people's health trajectories. And here's why some doctors think that this would be a good idea. The ACE study found that there were associations between the number of childhood adverse experiences that participants experienced and their risk of developing a number of mental health and physical health conditions. Here you see this is a different dose response curve than you're used to, but you can see a similar dose response association, linear association between the number of ACEs that people endorsed and their risk of developing depressed mood in the past year. They have similar effects with respect to suicide attempts. You can see here a dramatic 17-fold difference in risk of suicide for those who have 4 or more of those ACEs compared to those who were not exposed to any of those childhood adversities. You see similar patterns with physical health. So you see with severe obesity defined as a BMI of 35 or higher, those who have 4 or more ACEs are much more likely to suffer from it. Similarly, for heart disease, and also bronchitis or emphysema. Here you see higher prevalence rates for those who are exposed to more adversity. In another report, they looked at behavioral comorbidities. So these are issues like substance abuse, sleep disruption. They counted up the number of disrupted behavioral patterns, and these also show a gradient with ACE scores. These findings are correlational, so we still need a lot more research just to try to understand what it is about these adverse environments that are causing, perhaps causing these effects. There's a lot more research. I had put some of the reviews out there, up here that you could look up on other health outcomes that have been linked to early life stress, type 2 diabetes, some types of cancer, hypertension, and so on and so forth. But for the most part, the patterns that they've reported in the ACE study have held up and been replicated in other epidemiological studies. The next frontier here for us is trying to understand the pathways that lead from childhood adversity to health outcomes. In this study, we analyzed data from the Midlife in the United States MIDAS study, where we had access to data from more than 1,000 participants, and they provided information on both ACEs and they provided blood samples for assessing inflammatory biomarkers, so things like C-reactive protein, interleukin-6, and so on. And what we found here was that those who had been exposed to more adversity in childhood had elevated levels of inflammation according to this panel of 5 biomarkers that we had used to, in this study. And what this suggests is we know that these inflammatory markers like C-reactive protein and IL-6 can forecast the onset of cardiovascular disease later on. And so we think that this may be part of the pathway through which adversity might get to affect cardiovascular outcomes. To try to dig deeper into the pathway from adversity to inflammation, we looked at a number of other indices, and here we found evidence that higher levels of norepinephrine in urine output were correlated with both with adverse childhood experiences and with inflammation. We also found that higher waist circumference, greater levels of cigarette smoking, and lower levels of exercise were all significantly associated both with ACEs and with inflammation. And so these are showing some of the potential hypothesized pathways between ACEs and inflammation, though of course this is still correlational work, so we need to do more sort of intervention studies and experimental design studies to figure out the mediating pathways. Another potential pathway for the effects of childhood adversity on later health is the interaction between psychosocial stress and chemical stress, as you will hear more about throughout the day. This is one study looking at childhood asthma, and what's interesting about this study is that it recruited children between the ages of 5 and 10 who were asthma-free and followed them prospectively over time to see the onset of new cases of asthma. Also, at baseline, they assessed levels of parental stress, perceived psychological stress, so to the extent to which the parents felt that their lives were uncontrollable, overwhelming, unpredictable. And what you see here is that traffic-related pollution increased the risk of new asthma cases much more strongly for those who were from families where parents reported high levels of stress than in families where there was low level of stress. So what's being shown here is the hazard ratio associated with traffic-related pollution. And so this is an interaction effect between objectively measured indicators of traffic-related pollution for families and family psychosocial stress in predicting new cases of asthma. So it's important to focus on children, I think, because they're more vulnerable to psychosocial stress. They have immature coping skills and emotional regulation skills. All of you probably know more about this than I do, but a recent review suggested that children may also be more vulnerable to contaminants because relative to their body weight, they consume more food and water and breathe in more air. Young children, of course, like to eat dirt, and they spend a lot of time close to the ground. They have a more immature metabolism, and also this is a period of intense brain development and development in many organs and systems. So the fact that they're more vulnerable to both psychosocial stress and environmental stress, and that those two interact synergistically, are, I believe, reasons to focus on childhood as a particularly important period for prevention and intervention. So what can we do with respect to prevention and intervention? In my own work, I've tried to focus on some protective factors against childhood stress, and specifically social support and supportive relationships. In this review paper, I reviewed the literature showing that across development, humans experience lower or dampened stress responses when they receive support from their conspecifics. To give you an example of how we would come to this conclusion in an experimental lab-based study, I will tell you a little bit about my dissertation study where we recruited 9 and 10-year-old children to come to the lab and do a stressful task. This is a public speaking task where they have to give a 5-minute speech to introduce themselves, pretend they're the new kid in the class, and they have to say one good thing and one bad thing about themselves. And what we showed here is that when children prepared for this speech with a stranger, they showed a robust increase in salivary cortisol according to these salivary cortisol samples compared to a day 2 rest control. So they had a robust HPA response to this public speaking task. However, the children that we randomly assigned to receive parent support before giving their speech, even though they were still alone when giving the speech and this was still stressful, parents blocked the production of cortisol and the stress response to this future stressor that they experienced. So this is, because this is, it has random assignments, experimental design, we know that parents can buffer or block stress responses for children, and they do this in many different ways throughout the day. Why should we care about these small decreases in salivary cortisol in a lab setting? I think this that the accumulation of many of these buffering instances across the lifespan could potentially be consequential for physical health outcomes. You can see in this study, that's again from the Midas sample, where Miller et al. Looked at people's memories about the extent of maternal nurturance that they received before age 18. And you can see that low socioeconomic status early in childhood, which is here assessed by parents having less than a high school degree. So here shown, those who were most vulnerable were those who had parents without a high school degree. They showed an increased number of metabolic syndrome components. So obesity in the midsection, insulin resistance and so on, but only if they had low levels of maternal nurturance, shown there in purple. The ones who had high levels of maternal nurturance early in life, shown in black, did not show any effect of low socioeconomic status on risk of metabolic syndrome. So they were buffered or protected from the potential increased risk of metabolic dysfunction associated with growing up poor. So again, this is a correlational study, but if we could connect the dots between early maternal nurturance and later health outcomes, we know that cortisol plays an important role in metabolism, then we perhaps have a model of how we might intervene to help children. I have just a few ideas here of interventions that would be beneficial. We have a lot of empirical evidence to show that we have ways to reduce psychosocial stress in children and adolescents. There are effective maltreatment prevention programs where nurses visit new low-income teenage mothers to help them take care of their newborns. This results in lower incidence of child visits to the ER and child injuries. We also have a number of effective poverty reduction programs. Food stamps and the earned income tax credits have been shown by researchers at UC Davis to have beneficial effects on families. Even a little bit of extra income can reduce family stress and reduce negative outcomes for children. And finally, we need to promote environments that are conducive to a healthy development in children. And this is just an idea, a wishful thinking list of things that we could do to help promote healthy development in childhood: reduce exposure to contaminants, provide access to health care, restrict high sugar beverage sales and cigarette marketing and availability for youth, and finally, access to green spaces that are safe for physical exercise, as we have increasing evidence that physical exercise can also reduce or buffer some of the effects of stress on our bodies and can reduce allostatic load. Thank you very much for having me. Feel free to contact us if you think of any research projects that we could help with. We are very committed to research that might reduce stress for children and adolescents and might improve their health over time.